First, we will talk about what a stroke or a CVA is. You might recognize this image. FAST stands for face dropping, arm weakness, speech difficulty, and time to call 911. This is to easily recognize a stroke. Strokes are the third most common cause of death, and the leading cause of disability at an older age. Strokes have a mortality rate from 20 to 25%. There are two types of strokes. An infarction, which causes 80% of all strokes, or a hemorrhage, which causes slightly less than 20% of all strokes. An infarction occurs when the blood vessel is blocked. This can be due to atherosclerosis, which is a buildup of fatty deposits, which ultimately can block the blood vessel, or a thrombosis, which is a blood clot. A hemorrhage happens when a blood vessel starts bleeding. This is most commonly caused by an aneurysm, which is a balloon-like structure filled with blood. The bigger the aneurysm, the greater the chance of its rupturing. There are certain risk factors for developing a stroke. Those are old age, hypertension, diabetes, obesity, smoking, and alcohol consumption.
When a stroke occurs, a lot of processes take place in the brain. You first got the stroke, then you got the repair phase, in which neuroplasticity plays an important role, and in the end it has to lead to recovery. But before repair can start, the stroke induces damage, and this is called degeneration phase. Animal models have shown that when you cut an axon, what's done over here, there are two phases of degeneration. First, you get anterograde, which happens fast because there is no contact anymore with the metabolic center. And then you get retrograde degeneration, which progresses gradually in 2 to 3 days. Furthermore, there is transneuronal degeneration, which means that the degeneration of one neuron influences the following neuron, or anterograde, and the previous neuron, the retrograde, to degenerate as well. Degeneration is influenced by hypometabolism, edema, axonal growth inhibition, and missing neurotransmission. After loss of tissue, the brain will start to partly recover itself, and it will do this in two phases: the cell genesis, in which new glial cells are formed, in which new neuronal cells are formed, and in which new capillaries are formed. And then you get the adaptive plasticity, and this is more the forming of new neuronal networks. An important part of this is the axonal sprouting. Axonal sprouting is when you get two axons with synapse. When one degenerates, the other one will take over the synapse. And this is important because the peripheral nervous system, or opposed to the peripheral nervous system, the central nervous system does not have the capacity of regrowing an axon. All these phases, these two, go together with therapies given in the hospital and in the revalidation center, but it's still unclear what phase accounts for what part of the recovery. These two are the elements of spontaneous recovery from the brain after a stroke. They show general neuroplasticity of the brain. But now we will discuss in more detail how the retrieval of language works in the brain after a stroke.
Researchers agree that, in most people, the left hemisphere is the dominant one for speech. This conclusion dates back to Paul Broca and Carl Wernicke in the 19th century. Paul Broca had a patient with damage to the left frontal lobe that caused non-fluent aphasia. Today, this area is known as Broca's area, responsible for speech production, and, if damaged, for the disorder Broca's aphasia, characterized through an inability of producing fluent speech. A little time later, Carl Wernicke discovered that lesions to the left temporal gyrus also resulted in deficits in language. This area is now called Wernicke's area and is widely known to be responsible for speech comprehension. Lesions to it cause Wernicke's aphasia, which is characterized through nonsensical speech. Aphasias are, in general, disorders of speech associated with damages to a specific brain region. This damage may also be caused by a stroke. Patients that have stroke-induced aphasia show a spontaneous recovery to a certain extent. Some researchers say that surrounding areas of the damaged tissue are responsible for this phenomenon. like Baker and colleagues, who stimulated leftover language centers in the left hemisphere in aphasic patients and observed an improvement in recovery. However, other researchers claim that contralateral regions take over compensatory actions for the loss. For example, Rosen and colleagues reported an increased activation in the brain area contralateral to Broca's area in aphasic patients. But who's right now? Heiss and Thiel proposed a solution to the problem, which is also where most of the evidence points to. They proposed that minor damage to the language areas causes surrounding regions to compensate for the loss. However, if there's great damage, contralateral areas are activated for compensatory actions, but these actions only cause a minor improvement in language. Therefore, a full recovery of speech is only guaranteed if there is minor damage to primary functional language centers. But which treatments are available today?
The first way of putting those theories into practice is by making use of melodic intonation therapy, or MIT. This approach is based on the idea that left hemisphere activity for language can be replaced by right hemisphere regions that are responsible for singing in healthy brains. Ultimately, the patient should stop singing overtly and improve their spontaneous speech. The following video shows the different steps that are taken from singing to speaking. It starts with only a melody that is repeated by the patient. After that, intermediate steps between singing and speaking are shown. The first step, which is basically just singing simple sentences, is called intoned speech. Once this is mastered by the patient, Sprechgesang sets in, which is even closer to speech. In the end, normal speech is put into context. Also pay attention to the emphasis on rhythm and the movement of the left arm. This additionally stimulates the right hemisphere.
Goedenavond, buurman. Goedenavond, buurman. Goedenavond, buurman.
Buurman,
Goedenavond, buurman.
goedenavond, buurman.
Je ziet de buurman in de tuin en je begroet hem.
Ik zeg goedenavond, buurman.
Nou, helemaal netjes.
In the Netherlands alone, there are 15 different locations where MIT is offered for aphasic patients.
Another way of treatment is called constraint-induced language therapy. The therapy has three principles: constraint, forced use, and masked practice. Constraint means avoiding the use of compensatory strategies such as gesturing, drawing, or writing. Forced use means communicating only by talking, and masked practice refers to therapy occurring 2 to 4 hours per day. In the video you are about to see, aphasia patients are doing an exercise called material constraint. A set of cards is split between the players. On these cards are pictures of common objects like, I don't know if you can see it, but cows or guitars. The patients have to ask each other if they have a certain card, and they have to answer each other if they have the card. According to some studies, this therapy helps the patient to speak better again.
Do you have a red or white card and a black sandals? Do you have a white card and a white sandals?
Sandals? Card? No, we don't.
So, Francis, the whole phrase is say, I don't have
a white card or a white
just gives us
Sandal.
Good.
Good job, Francis. Good.
Thank you.